as I'm a disciple of Michael's, everyone knows Michael Gorton in the health sector, and today I'm talking to you about how poor surgical outcomes can result in disciplinary sanctions, and then hopefully trying to sort of tie that back into today's seminar. So there have been relevantly a number of cases over the last decade, both before the Medical Board and the various Health Complaints Commission, that have resulted in disciplinary sanctions against practitioners for poor surgical outcomes. And I'm going to talk you through a couple of cases today. And the issue here is that whilst poor surgical outcomes, can and do arise, in the context of disciplinary action, we tend to see disciplinary action being taken in response to poor surgical outcomes where issues have been agitated by the patient or their family members, and sometimes too over concerns raised by colleagues, particularly in relation to overzealous conduct of practitioners. And where sanctions are taken, it usually is because of the conduct of the individual practitioner and not as a result of a systemic failure of the system. In relation to trends, there have been a number of recent disciplinary cases that suggest common trends giving rise to poor surgical outcomes include a failure of the practitioner to obtain a second opinion from a relevant specialist when a patient presents with symptoms evident of conditions outside their particular area of expertise, a failure to obtain informed consent or discuss non-surgical treating options with the patient, breaching existing licence conditions, so that's where the board have imposed licence conditions in relation to restricting the practice of certain kinds of procedures or undertaking procedures with the assistance of other surgeons, failure to accurately document the patient's medical history and symptoms leading to misdiagnosis, and poor post-operative practices in communication between treating physicians. I've seen a couple of you madly taking notes. I'm happy to share a copy of my presentation with VASM if that assists, so you can just sit back and relax. So I'm going to take you through a couple of noteworthy cases, and I'm going to go into a little bit of detail about the factual, a bit ahead of myself here, about the factual scenarios in these. But before I do, I just wanted to draw your attention to this figure that was produced in AHPRA's annual report last year. And it's interesting in terms of clinical care being the highest category of notifications to AHPRA, and the issues relating to communication, documentation and so forth, and then the individual circumstances of the practitioner typically being very much down the spectrum in terms of issues that arise. Okay, so in relation to those cases, the first one is a very recent case, and it's quite a long history. And at the time that the matter finally got before the tribunal, the practitioner had voluntarily handed over his registration, so he was unregistered at the time. But I'll take you through the facts of it, and I'll also explain the outcome. This related to a range of breaches of the national law over a number of years. The practitioner, Dr. Reid, was a specialist gynaecologist, and he'd consulted 17 women. So these issues resulted to 17 different cases, and those consults related to complex urogynecological conditions such as urinary and fecal incontinence and vaginal damage or prolapse, and that had been sustained through childbirth. And Dr. Reid did not have a conservative practice, and he had a rather a tendency to adopt integral theory paradigm and tissue fixation system surgical practice, which at the time had been removed from the TGA register, but also had not been subject to clinical trials in Australia at that time that these cases arose. And in this context, Dr. Reid was found guilty of unprofessional conduct and professional misconduct for various complaints brought under the national law. He was not registered, as I said, at the time these disciplinary matters came before the tribunal, but the tribunal stated that as a result of these complaints, had he been registered at the time, they would have suspended his licence for 5 years, which is quite a significant sanction. So I'll take you through the breaches in a little bit more detail to help you get a sense of what the issues were. So Dr. Reid failed to obtain a second opinion before operating on patients who had a complex urogynecological or colorectal histories and previous unsuccessful operations, including those that he had performed himself. He failed to document his pre-surgery discussions with his patients and failed to obtain written consent from patients to use TFS surgical mesh. He also failed to adequately document his clinical justification for using the radical procedure on patients. And these were found to be breaches of relevant regulations and standards of practice at the time. Dr. Reid also inappropriately decided to perform TFS surgery on patients in circumstances where it was both inappropriate course of action and did not actually address the patient's clinical symptoms. He performed vaginal tape surgery on patients, which was not in their best interests compared to other available surgical procedures, and he failed to document his discussions with the patient, alternatives, risks and benefits of the proposed techniques that he adopted in those cases. He used a permanent polypropylene rather than a dissolving mesh during surgery to treat an immunocompromised patient, which carried a high risk to that particular patient. And in relation to another patient, he readmitted a patient for a second surgery without waiting a safe amount of time from his previous surgery and risking serious injury. The tribunal found that together, the many instances of his conduct demonstrated that the practitioner's clinical judgment fell significantly below the conduct reasonably expected of a practitioner of his level of training and experience, and therefore constituted professional misconduct. The next case, Dewan and the Medical Board of Australia, this is an old case, but it's quite an interesting one. It relates to Dr. Dewan's misdiagnosis of a child's toileting issues and as a result of correct evidence which resulted in the misdiagnosis. And the tribunal in this case found that Dr. Dewan failed to take a proper history from the patient's treating physicians and failed to conduct proper diagnostic testing in the lead up. And he also failed to seek a second opinion in the circumstances. Significantly, in this case, from a surgeon's point of view, he failed to offer non-surgical options which had a good chance of success in that particular patient's case. He also failed to give an adequate warning of the risks of the surgical procedure, which was found to be a breach of the requirements for informed consent. Ultimately, the procedure was unsuccessful and resulted in long-term bowel issues for the child due to Dr. Dewan perforating the patient's bowel. He was found guilty of unprofessional conduct and professional misconduct as a result of his conduct as well as of his lack of remorse. And that was a significant finding and consideration in the sanctions that were placed on him by the tribunal. He ultimately had a condition placed on his licence for an audit of his practice and that he received a 12-month suspension and a reprimand. He was also ordered to undergo counselling and additional education. The next case, Dr. Martin, he was a GP found guilty of unprofessional conduct and professional misconduct for his mismanagement of patients and providing false and misleading information to APRA. And this is really interesting. It was in relation to his conduct of surgical procedures in the context of management, testing and diagnosis of skin cancers. And in the first instance of unprofessional conduct leading to an adverse surgical outcome was in relation to a patient presenting with a Merkel cell skin cancer, which had spread to the lymph nodes, bones and liver. It was argued that Dr. Martin mismanaged the patient's care by not referring them to a specialist until 2 months after the initial diagnosis, and Dr. Martin failed to excise the tumour with a large margin. Instead, he, and I'm going to get this wrong, bifurcated the skin lesion, which was an inappropriate course of treatment in that patient's situation. The tribunal was satisfied that this constituted unsatisfactory professional conduct in the circumstances. The second instance, Dr. Martin was found guilty of unprofessional conduct, was failing to perform surgical removal of a skin cancer in line with appropriate treatment protocols. In this matter, Dr. Martin performed a shaved biopsy and bifurcation of a skin lesion on the patient's right temple. Dr. Martin further bifurcated a basal cell carcinoma on the patient's right temple, but did not send it off for testing. The patient experienced persistent pain, ulcerations with the lesion, and Dr. Martin subsequently re-excised it. However, he later admitted that formalised treatment requires surgical removal, as the tumour can slowly invade the deeper tissue. There were a number of other grounds that led to unprofessional conduct and findings of professional misconduct, which related to his provision of false and misleading information to APRA and also the Coroner's Court. In relation to one matter, it related to the death of a patient of his who had died within 24 hours of consultation. So as a result of these culmination of conduct issues, he was suspended for 12 months and also reprimanded. This last case I want to take you through involved Dr. Hocking, an adult and pediatric... Thank you. I stumble on this one. Pediatric orthopedic surgeon, and he was reported by his colleagues that he worked with in the hospital due to concerns that his conduct had amounted to a significant departure from accepted professional standards in relation to 2 pediatric patients. The first patient, patient B, was born with a congenital hip dysplasia, and Dr. Hocking, in her case, recommended a 2-stage treatment, which would involve 2 surgeries. After the first surgery, he produced a report which detailed his findings and then performed the subsequent procedure. However, some 3 to 4 months later, Dr. Hocking produced a second, more detailed account of the surgery after he became aware of a complication which had followed from the first surgery, which could lead to disciplinary proceedings. In the second report, Dr. Hocking amended the descriptions of his conduct and the procedures that he undertook. Nothing wrong with that, is there? After declining symptoms, the patient's care was taken over by another physician who discovered by medical imaging before and after Dr. Hocking's procedure that significant bone had been removed, leading to critical destabilisation of the hip joint and rapid destruction of the hip itself. It was discovered that the procedure undertaken by Dr. Hocking removed bone from the patient's hip socket as opposed to the procedure outlined in the second report, and that in the patient's circumstances, the bone removal procedure was not indicated by the patient's medical condition. Patient A, Dr. Hocking diagnosed the 9-year-old with an inflammatory disease, Perth's disease. Initially, Dr. Hocking treated the patient with steroid injections, but he believed surgical intervention would be required. He foreshadowed the procedure with the patient's family, telling him that he would plan to coordinate the procedure within 3 months. However, Dr. Hocking did not inform the patient's family that he was prohibited from performing this particular type of procedure due to existing restrictions on his licence. he did not refer the patient to another practitioner who was able to perform the surgery. You see here there's a bit of a history with some of these practitioners. Around the same time, he also proposed a novel treatment of platelet-rich plasma injection for the patient, which he had not previously used on patients with Perth's disease. At the time, the treatment did not have any published supporting research. However, Dr. Hocking informed the patient's mother that his colleague in another state was performing it with good results. He failed to admit it was in relation to the particular condition that the patient had. He subsequently put the patient under a general anaesthetic and performed the platelet-rich plasma injection. In this case, the board received an anonymous notification which asserted that the treatment administered was unwarranted therapeutic experimentation and placed the patient at general risk under a general anaesthetic, and infection without evidence of the treatment's efficacy or safety in the patient's circumstances. Significantly, as a result of that notification, immediate action was taken by the board to suspend his registration. And the tribunal later found that the platelet-rich plasma injection had never been before used in Australia in this context, but interestingly, Dr. Hocking was not sanctioned for this issue. Really, what the tribunal picked up on in those instances were the consent issues and the way in which he'd managed informed consent with the patient's family. And he felt that it was misleading information to persuade the patient's parents to proceed with the novel procedure. For the conduct in relation to both these instances, Dr. Hocking was found guilty of unsatisfactory professional performance by performing a complex hip surgical procedure which was contrary to the patient's condition. Also in relation to failing to disclose a restriction on his registration, he was found to have engaged in unsatisfactory professional performance. Also, by fabricating a second report for the hip surgery on patient B to indicate the symptoms the patient suffered were not due to the way he carried out the surgery. And also in relation to failing to refer patient A to another paediatric orthopaedic surgeon who was not restricted in carrying out the surgery. It was quite interesting the kinds of sanctions that the tribunal imposed on Dr. Hocking's licence, and the requirements were quite specific to address the concerns about his behaviour, and these included that he discuss preoperatively all complex cases with suitably qualified surgeons and follow up with presentation of all post-operative outcomes of the same procedures during the post-operative period. He had higher auditing requirements imposed on him, and he was only allowed to practice in a public departmental setting. And in relation to complex surgeries, he could only undertake these at a time where a second surgeon could join. So I just wanted to sort of open it up for you to consider. Can poor surgical outcomes give rise to mandatory notification? And when we think of mandatory notification obligations, we usually think about the surgeon's competence and capacity and also professional boundary type issues. We tend to forget that health practitioners also have an obligation to notify of conduct which places the public at risk of harm because the practice constitutes a significant departure from accepted professional standards. And when we talk about accepted professional standards, who is in the best place to evaluate whether or not a colleague's conduct falls below those standards? You are. You're in the best place to evaluate those. And importantly, the test here is not a requirement for a poor surgical outcome. The test here for a mandatory notification is that the conduct is capable of placing the public at risk. The risk doesn't need to eventuate. It's just that the proposed conduct, or the actual conduct if it does occur, represents a significant departure from acceptable standards. And it's not about just a dispute about the appropriate course of action or procedure to be taken in a particular case. That happens as part of the ordinary course of medical practice. But it's meant to cover matters where it involves a significant departure. And for example, if and it's more aimed at matters where there's almost negligent practice or engaged in an innovative practice that hasn't been used for that particular condition. So, in conclusion, thank you. Poor surgical outcomes can result in disciplinary action. It's rare, but it does happen. And largely, if practitioners acknowledge their errors, show remorse and a change in professional behaviours, they have only been found to be liable for unprofessional conduct. Instances where practitioners have been found to be liable for the more serious form of professional misconduct have generally been characterised by a practitioner's disregard for existing sanctions on their licence and a failure to show insight into their professional behaviour. In most cases, licence suspension occurs in these cases, and it's usually a 6 to 12 month suspension on their licence, a reprimand, and in some cases a fine. It's important to note that VASM helps keep surgeons current and safe through peer review and recommendations on continuous improvement. But importantly, as VASM is confidential and subject to the Commonwealth Qualified Privilege Scheme, which I think we'll hear more about shortly, the information obtained through VASM cannot be used for notifications or disciplinary processes. So obviously these issues sit outside of VASM. So it's really contingent on health practitioners, health services to manage these issues with their colleagues.